pleasure to introduce a dear friend and colleague, Professor Jade Ghosn, who's a full professor in the Department of Infectious Diseases at Bichat University, Paris, France, and he teaches in Bichat School of Medicine, Paris Cité Université in Paris. Professor Ghosn holds a MD in Internal Medicine and Infectious Diseases, a PhD in Virology. He's the head of the outpatient HIV clinic and head of the sexual health clinic in Bichat Hospital. He's also an active member of the French National Agency for Research on AIDS, Viral Hepatitis and Emerging Infectious Diseases, LSIDCM, where multi-center clinical trials are reviewed and implemented in France. Professor Ghosn's main research interests include primary HIV infection, resistance to antiretroviral drugs, the pathophysiology of HIV-2 infection, prevention of sexual and mother-to-child transmission of HIV, prevention of STDs, including bacterial STIs, HPV, and Mpox. Professor Ghosn has published a large body of work on HIV and STIs in peer-reviewed journals, including New England Journal of Medicine, The Lancet, Infectious Diseases, the Annals of Internal Medicine, CID, Clinical Microbiology, Infection, etc. And he is a leading HIV expert in France. And without any further ado, Professor Ghosn, the floor is yours. Hello.
You're muted, Jade.
Professor, we cannot hear you. Still not able to hear you. Please, can you try without the earphones?
Yeah, can you hear me now?
Yes, Professor.
Okay, great. So I'm just sharing my screen. I would like to thank Nisreen for this kind introduction, and I would like to express my deepest thoughts to all the colleagues who are currently in the ER or in the hospitals in Lebanon and struggling with the difficult situation the country is facing now. I was asked to talk to you about the biomedical prevention of STI. So first, these are my disclosures. And I would just like to start my talk by giving you an overview of the epidemiology of STI worldwide. In 2020, we had more than 300 million new infections worldwide for the 4 curable STIs, which are chlamydia, gonococ, syphilis, and trichomonas vaginalis. And as you can see here, there has been an increase that has been noted in European countries since 2007 for chlamydia, but also for gonorrhea and for syphilis. And this increase has been stable and sustained until 2022. And there are many reasons for the increase in bacterial STI. One of the first drivers is the increased detection due to lab technology and the availability of nucleic acid amplification tests, which are very performant, very sensitive tests. The other reason for this increase is some guidelines in some countries who recommend the detection of STI in extragenital sites, such as in pharyngeal swabs or in the rectum. And some guidelines do recommend to do this every 3 months. So if you search more, you will find more. And this has been also a driver for this increase. Another reason is the increase in condomless sex, the increase in the number of sexual partners, and sometimes the longer duration for untreated infections. And to illustrate this, I would just want to show you this study that was performed in Sydney with a survey in MSM in Sydney between 1997 and 2016. And as you can see here, there is a sustained decrease in the systematic use of condom and a sustained increase in the use of condom sometimes, but not always. And this has been really not related with PrEP use, because you see this decrease has started at the early 20s, and PrEP has been launched in Australia in 2016. So this is really not related to PrEP use. This is also another illustration in New York City sexual health clinics, with the increase in sexual partners across time. And as you can see, the proportion of individuals who are reporting more than 2 or 3 sexual partners has been increasing since 2011. And this is really before the launch of PrEP. And also, most of STI that we are diagnosing are asymptomatic. So if there are not recommendation for regular screening, these more than 70% of these STIs will be missed, and this can continue to fuel the dynamics of secondary transmission and sexual transmission of STI, and potentially increase the burden of STI worldwide. This is also another illustration in the US. As you can see, this increase has been noted since 2007. There are many explanations, such as the launch of the iPhone and the launch of the apps on the iPhone, such as dating apps, such as Grindr, with an increase in sexual partner. But also, we don't have to forget that in 2008, Bernard Hirschel in Switzerland issued the Swiss statement assessing that an HIV individual who has an undetectable plasma viral load and who is strictly adherent to his treatment cannot transmit HIV through sexual intercourse to his sexual partner. And this has been also a driver of less fear of sexual transmission of HIV, and might have also decreased the use of condoms systematically. We also had the results of HTPN 052, the randomized trial who confirmed the fact that HIV treatment acts as a very powerful tool for prevention of sexually transmission of HIV. We had PrEP in 2012 in the US, and the CDC guidelines for STI screening every 3 months, and also in extragenital sites. All of these factors might have contributed to the increase in the detection of STI. So to prevent STI, we have condoms, we have screening, we have partner notification, and we have vaccine. But what is new? The news is doxycycline as post-exposure prophylaxis. So I'm gonna go with you through the results of the ANRS DoxyVac trial that was conducted in Paris and the suburban area. And this trial was focused on MSM on PrEP with a history of bacterial STI in the prior 12 months. This was a multicenter 2x2 factorial randomized open label trial, which compared doxycycline as post-exposure prophylaxis between 24 and 72 hours post an unprotected sexual intercourse versus no post-exposure prophylaxis. And another comparison was the 4C-MenB vaccine compared to no vaccine to prevent from gonococcal infection. So doxycycline, the primary outcome was the first episode of chlamydia or syphilis. And for the vaccine arm, the primary outcome was the first episode of gonococcal infection. So this is the flow chart. More than 500 individuals were randomized. And as you can see here, I just want you to focus on the loss to follow-up line. There was really very few individuals who were lost to follow-up. So we had a very good retention in the trial throughout its completion. So this is the first result for the doxycycline post-exposure prophylaxis arm. The time to first chlamydia or syphilis infection. And you can see here a dramatic effect of doxycycline post-exposure prophylaxis for the prevention of the first episode of chlamydia or syphilis, with an 84% reduction in the incidence of chlamydia or syphilis. And this is split between chlamydia and syphilis, and you have the same results. A dramatic impact of doxy-PEP on the incidence of chlamydia on the left-hand side of the slide, and syphilis on the right-hand side of the slide. We were also surprised because we had a small effect of doxycycline as post-exposure prophylaxis on gonococcal infection, with a 51% reduction in the incidence of GC in the doxy-PEP arm versus no doxy-PEP. And this was surprising because in France, we have high levels of resistance to tetracycline in for GC. But despite that, we had a 51% decrease in the incidence of GC infections in the doxypep arm. There was also another trial which was focused on women in Kenya, doxycycline post-exposure prophylaxis. And as you can see here, there was absolutely no effect of doxycycline PEP versus standard of care for the first episode of chlamydia. One of the explanations that was first thought about was the fact that maybe doxycycline does not penetrate as much in the vagina, as much in the rectal tissue. But this was not confirmed by studies of penetration of doxycycline in plasma and rectal and vaginal secretion. And as you can see here, there are very good concentration achieved in the vagina for doxycycline, which are very much the same as those who are achieved in the rectum. So this cannot be the explanation of the absence of effect of doxypep in the women-focused trial. And the main explanation is adherence. The adherence was really poor in this trial, which led to the absence of impact of doxypep for the first episode of chlamydia. So we have now 3 major trials who have demonstrated the high efficacy of doxypep to prevent chlamydia and syphilis infection. The IPERGAY that was published in 2018, the doxypep study that was conducted in the US published in 2023, and the doxyvac study, which I have just presented, that has been published a few months ago. And in all these studies, doxycycline was used as post-exposure prophylaxis, 200 milligrams up to 72 hours following condomless intercourse without exceeding 600 milligrams per week. So 3 times a week, no more than 3 times a week. But because such an intake as post-exposure prophylaxis may lead to adherence issue, doxycycline was also evaluated as PrEP. So this is a study that was conducted in Tokyo very recently in female sex workers who were asked to take doxycycline on a daily basis, 1 pill, 100 milligram every day. And we had data of the incidence of STI in these female sex workers before and after they started doxycycline as PrEP, which means 1 pill every day, regardless of sexual intercourse. And you can see a major impact of doxycycline taken on a daily basis, 100 milligram, on the incidence of chlamydia, GC, and syphilis. The same way of taking it, doxycycline PrEP, on a daily basis, 100 milligram, was also conducted in Canada in HIV plus MSM, with significant results in favor of doxy PrEP, so taken on a regular basis, on a daily basis, 100 milligram. And also it showed very high impact on the reduction of the incidence of syphilis and chlamydia in HIV plus MSM in Canada. So what do guidelines say? Until now, we have the EACT, the European guidelines that were issued in 2023, which are a little bit cautious and say that doxycycline as PEP, post-exposure prophylaxis, can be proposed to persons with repeated STIs on a case-by-case basis. The CDC issued guidelines in May 2024, which are much less stringent than the EACT's guidelines. So CDC recommends the use of doxycycline PEP in MSM and transgender with a history of at least 1 STI during the past 12 months. But they also said that the use of doxycycline should be also discussed in MSM and transgender women who do not have a bacterial STI history and who are at risk of getting STIs. And this can be discussed even if they do not have a history of STI. So it's a little bit less stringent than the EACT's guidelines. The French guidelines have just been issued a few weeks ago, and they are a little more stringent than the US. They said that doxycycline post-exposure prophylaxis cannot be recommended for the prevention of bacterial STI. However, it can be discussed on a case-by-case basis in MSM and transgender women who have more than 2 STIs in the last 12 months. So this is the way that French guidelines have endorsed doxycycline PEP. What about for CMNB vaccine? So this is the Bexsero, the vaccine against meningococcal B, which share similar epitopes with gonococcal bacteria. And this is why it has been thought that the 4CMNB vaccine might have an impact on the incidence of gonococcal infection in people at risk for bacterial STIs. So in the DoxyVac trial, this is the results of the 4CMNB vaccine arm. And as you can see here, there was no significant impact of the vaccine on the time to first gonococcal infection with regards to no vaccine. And you can see the Kaplan-Meier curves, which are very similar. And we were not able to demonstrate any impact of the vaccine for the reduction of a time to the first gonococcal infection. So this was a little bit disappointing, but these are the results that we got from this randomized trial. We tried to look at different outcomes to see if the vaccine could have an impact on some anatomical sites versus others. So we thought that maybe the pharyngeal site was maybe less prone to be impacted by the vaccine, and maybe the anal site or urinary site might be more prone to be impacted by the vaccine. But as you can see here, whatever the site, there was no impact of the vaccine. Whether the infection was symptomatic or not, there was no impact of the vaccine. Whether the infection had a positive culture in addition to the positive PCR there was no effect of the vaccine. And there was also no effect of the vaccine on cumulative incidence of gonorrhea infection, whatever the site. So to sum up for doxycycline PEP, we now have 3 large studies that have shown strong reduction of chlamydia and syphilis infection among MSM and transgender women. It's less effective against gonorrhea. DoxyPEP is well tolerated with high adherence, and implementation studies are underway with monitoring of antibiotic resistance. What about for CMNB? The clinical relevance seems very limited with regards to the results of the DoxyVac trials. Similar rates of cumulative infections, symptomatic infection, and culture-positive infections. But there are other phase 3 trials who are ongoing, and we are waiting for the results. So what do French guidelines say about 4CMNB vaccine? The guidelines have been issued, as I told you, a few weeks ago. So the guidelines do not recommend a 4CMNB vaccine against gonococcal infection. As we are talking about the vaccine, I just wanted to stress about the fact that French guidelines do recommend vaccine for prevention of Mpox in MSM on PrEP, based on many studies. One of them I had conducted in Paris and the suburban area. And as you can see here, in the population of the DoxyVac trial, so MSM on PrEP with a history of STI, who were at high risk for Mpox infection, you can see here the incidence after the launch of the vaccination campaign in 2022. And you see the dramatic drop in the number of cases after the launch of the vaccine campaign. And you can see here the very good rollout and acceptability of the vaccine among participants to the trial, and the very low number of cases after the launch of the vaccine. So to conclude, you have now several tools for STI prevention in 2024. Please don't forget condoms, screening, partners notification. What about the future? DoxyPEP has been recently endorsed in guidelines. We have to see how it's going to be implemented in real life. And we still need specific vaccine against gonococcal infections, because the 4CMNB vaccine does not seem to have a very significant impact on incidence of gonococcal infection. So there's many questions still unanswered, many challenges to be met, and many studies to be carried out. Thank you, and I'm available to answer any questions at the time for the Q&A. Thank you.